Good morning, everyone, and welcome to this cold, snowy morning. So those of you in the chamber, thank you for making the effort and taking the perilous journey across Staffordshire, snowy Staffordshire this morning. So good morning, it is 10 o'clock, we are now live. It is Monday the 29th of November 2021. Welcome to the County Council Chamber for this meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I am your Chair, County Councillor Jeremy Pert. May I remind committee that today's meeting is being recorded, and for those who want to watch back today's session, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved and will cut off 20 seconds after the equipment has stopped. All voting committee members are in the chamber this morning, and there is a variety of people online, so welcome to those online. Can I also thank our guests in advance for their input so far and for their time. So can I ask today's presenters that we restrict the opening comments to around 10 minutes. I will be somewhat flexible, but please don't take an hour, so that we can spend sufficient time scrutinising the work. And can we also focus in on tangible outcomes for the residents of Staffordshire? However, before we start, I'd like to recognise two things. Firstly, to recognise that during the pandemic, it was right and proper for this committee to focus on the immediacy of the response as the virus morphed and changed. But over the last 12 months, we are a health and social care committee, and we needed to pick up the ante on all aspects of health and social care, including positive public health outcomes for our residents, particularly those most vulnerable or furthest away from help and support. And I'm sure we will focus in on that this morning. We will, of course, come back to looking at some of the institutions within the NHS in 2022. Secondly, I'd like just to also recognise the pandemic is far from over, and in picking up the COVID update later on this morning, I would like just for all of us to recognise that we have a community leadership role at county, district or borough level to encourage others to be as safe as possible so that we can adapt and to learn to live safely with COVID, much as we have done so with flu. So let's start this morning by welcoming back an old familiar face, less old but certainly familiar face to this committee in Jonathan Lindrop, who is standing in for Deb Breeden just for this morning. And equally, let's wish Deb a swift recovery, and I think she will be back with us midweek, so certainly in time for the next session of this committee. So let's start with item 1, apologies.
I have apologies, Chairman, in no specific order, from Barbara Hughes, Janet Johnson, Rosie Claymore, Ian Wilkes, Phil Hewitt, Janice Sylvester Hall, Colin Wildman and David Latham. Thank you.
Thank you. Can I just confirm we're quorate?
Yes, Chairman.
Thank you. So just in terms of those apologies, Councillor Joyce Bolton has stood down as chair of the relevant committee at district or borough level. So I'd like just to thank her for her input to committee and also to welcome back a familiar face, which is Janet Johnson, who will be with us at the next meeting. And I'd also like to welcome Councillor Daniel Maycock, who is substituting for Rosie Claymore this morning. So welcome to committee. Second of all, declarations of interest. Anne Edgeler.
Thank you. Good morning, everyone. Yes, I'm partner governor from the County Council on the MPFT. Thank you.
Any other declarations of interest relevant to this morning's agenda? No, I will take that as no. So let's move on. So item 3, minutes of the meeting 25th of October 2021. Can I ask if the minutes are a true record of our last meeting for those of you who were there? I've got it proposed and seconded by Paul Northcott. Thank you. Are we all in agreement? That's fine, thank you, that is unanimous. And I'm reliably informed that all actions have been followed up and all information received to date has been circulated. Are there any matters arising that members are not aware of that is not on today's agenda? I'll take that as a no, and in which case, let's swiftly move on to item number 4, which is the overview of public health outcomes and services. And I believe that, Claire, you're going to take this away.
Yes, thank you, Chair. So just by way of a little bit of background, so we're here today in response to an invitation from the committee to bring an update on public health services and performance. There's myself here today, I'm Claire McIver, and I'm Interim Assistant Director for Public Health and Prevention at the County Council. I also have two of my colleagues with me, lead commissioners for, in fact, I'll let you introduce yourselves. Go on, Tony.
Hi, I'm one of the lead commissioners in the Public Health and Prevention team.
Hi, I'm Tilly Flanagan, another lead commissioner, sort of focusing on the supportive communities team.
Thank you. We're also expecting Karen Coker from the Children and Young People's Public Health team, who isn't here at the moment, so we're not sure that there's an issue with the weather and her getting in. So her section of the presentation is at the end, so depending on where we get to, we may have to sort of just cover the headlines and get some of any of those questions specifically fielded to Karen, so we'll see how we get on with that section. And I guess just by way of explanation, really, the public health programme in Staffordshire cuts across 2 directorates within the County Council. So Richard Harling, as the Director of Public Health, has the statutory responsibility for public health delivery and assurance and fulfilling those statutory duties. In terms of day-to-day operational and strategic leadership for the different agendas, Adults sits with our team, and the Children and Young People's Public Health agenda sits within Children and Families under Natasha Moody as the Assistant Director. And Karen Coke is the lead public health officer for that piece of work. So I think just by way of a bit of broader context and background, I suppose, and I'll keep this brief, we're obviously presenting some performance data today and an update on how some of our services have sort of been functioning over the past 18 months or so. I think it's always worth remembering that whatever we do within public health sits within a very complicated and complex sort of context, I guess, in terms of the wider determinants of health. So whatever's happening at a national level and a local level in terms of the economy and jobs, as well as what's happening in people's own lives in terms of their, their sort of their housing, their education, their upbringing, their social circumstances and personal circumstances, all has an impact on people's health and well-being. So it's always worth considering that context on those wider determinants of health in everything that we do, and we obviously do that in the way we approach our public health programme in Staffordshire. And wherever possible, we'll take that whole systems and upstream approach to what we do. It may be that we come back to this committee at a future date to discuss that level of work and the sort of broader spectrum of things that we do in more detail. The focus of today, specifically following the invitation, is around the performance information. So just, again, by way of a quick overview, I suppose, Staffordshire is generally a healthy place to live. We have a life expectancy that's similar to the national average, but there are some long-standing challenges, and we'll cover some of those today. We do face significant health inequalities, and by that I mean there are sort of significant disparities in terms of the outcomes that we see and people's health and well-being across the county. We have pockets of very poor health in some areas. And that's one of our biggest challenges, I guess, in public health in terms of how we reduce those inequalities and inequities and bring up all levels of health and well-being, not just for certain pockets of the population. We do, however, have a very strong public health programme, a really experienced team with lots of skills. We've been really successful at bringing in additional funding into the area in the last few years, so around £6 million of new investment into the public health programme. We've got a really strong record for innovation and partnerships and working across the communities as well, which is a real strength for us and a real sort of driver of how we achieve some of our significant outcomes. I think it's worth just referencing, and it goes without saying, I guess, that we've had a direct role in public health in terms of the COVID response over the last 18 months. So that has obviously had an impact on how we've been able to progress some of our programmes of work. It's also had a direct impact on some of our commissioned services. We are already starting to see the impact of COVID, both in terms of the actual disease itself, but also the result of things like the lockdowns. And we're seeing the impact in some of the issues that we already had in the county, but we're seeing those exacerbated and, in fact, some of those inequalities further widened. And I think what we need to keep an eye on, and we don't sort of truly know the impact of yet, is any of that hasn't started to filter through in the data and in our sort of outcomes reporting. So we're hearing lots of anecdotal information, for example, about increases in people having poor mental health, loneliness and isolation, alcohol consumption, all those kind of things that, you know, won't be a surprise to any of you here. But those are the things that we need to sort of start to build into our future programmes of work as well. In terms of the services that we commission and deliver directly, I think we can say that we've been really, really pleased at how they've responded, and actually have continued to perform really well considering the circumstances. There's been lots of flexibility, lots of adaptations that have been made to allow those services to continue. There's been one or two that we've had to pause, largely where that's NHS staff that have been diverted into things like the vaccination programme, but for the most part they've been able to continue, whether that be with restrictions on face-to-face support, creating a more virtual or sort of online platform. And actually a lot of those adaptations have been really successful, and we will continue to sort of offer those and build those into the future delivery model. So I think in that sense it's been a really useful learning opportunity for us with the services to see how we can do things differently and more flexibly in future. So with that, I'll hand over to my colleague Tony to just talk briefly about the drug and alcohol services.
Great, thanks Claire. The first slide there is a summary. We'll go into each of the points on separate slides in a bit more detail. But I think the overall picture with drugs and alcohol is quite mixed. There are some areas of continuing challenges, and there's some areas that we're performing really well on. Next slide, please. Claire's got the flicker, so I'm doing the Chris Whitty role of handing over to Claire for the next slides. One of the key challenges we've got is around drug-related deaths. The slide there, the black line is the national trend, and the Staffordshire line is slightly below it, as you can see. So it's a challenge locally and nationally. There's a whole bunch of different reasons for that. The main reason is likely to be the ageing population of drug users. Less young people are getting into drug dependency, and a lot of the people that we've got in treatment now have been there for a long time and started taking drugs a long time ago. A lot of people started taking drugs in the 80s and are still part of that treatment cohort. As they age, obviously they become more vulnerable. Most of the deaths aren't actually overdoses. They tend to be respiratory conditions or cardiovascular disease. Obviously with a chaotic lifestyle makes you vulnerable as you get older to different diseases. So we are seeing this trend of deaths, unfortunately, and Staffordshire is part of it. Fortunately, we are a little below the national average. Obviously, that's not something to be complacent about, and we're doing an awful lot to try and prevent those deaths, as we'll move on to. Thanks. So the slide there shows an increase in the number of people in treatments over the last year, essentially. There's a couple of reasons for that. One reason is that we expanded treatment services. We recognised that there was increased demand, and we've invested in the treatment services. We've brought in about £6.2 million over the last 4 years. Some of that's come from local partners. The Police and Crime Commissioner invests, North Staffordshire CCG invests, but we've also won a number of grants and research trials from central government. We get significant investments around the child safeguarding services. So these slides paint a very basic picture of what we do. Obviously, there's a lot more nuance within it. We're very proud about what we do around child safeguarding and the investment that we've had from central government. Similarly, schemes to get people into employment, we've won money nationally. So we've got more people in treatment over the last year or so. As I say, some of that is because of that investment and the expansion of the services, and some of it is because of increased demand following lockdown, particularly for alcohol. Again, it's very difficult to quantify the success or otherwise of a service, because we try and achieve a lot of different outcomes. For some people, it's about the very basic of keeping people alive. We also try and obviously protect children from neglect. We try and reduce crime. We try and improve health outcomes. One basic measure that summarises the success is how people leave the service. Do they drop out, or do they complete treatment successfully? So the blue line there is Staffordshire, the red line's national. The reason for the gap in the line is a data issue. When we handed over treatment services, there's a glitch in the system that isn't the fault of the local services. It's just how figures are measured, and when services hand over, it drops out. But the picture there is we're generally above the national average in terms of successful completions. So that gives us confidence that the services that we invest in are working well. Okay, sexual health. Again, a summary slide. We perform broadly very well in terms of sexual health. As always, there are some challenges that we'll go through, but the services that we commission and the state of sexual health in Staffordshire is pretty positive. So one of the key objectives, obviously, is to reduce the rate of sexually transmitted diseases. Again, the hard black line is the national average there, and the blue line is Staffordshire, and we've been consistently below the national average in terms of STI rates. And again, we think that's partly due to the demographics of Staffordshire, but again reflects the quality of the services that are provided. We can't be complacent, as the slide talks there. There is a new strain of gonorrhea that's presenting a challenge that appears to be resistant to some of the treatment drugs. And we're working with national and local colleagues to address that. But again, in terms of STIs, pretty strong performance there. Another key priority is around HIV. HIV rates generally in Staffordshire are below national averages again. But a second challenge is to try and diagnose HIV as early as possible. The earlier you diagnose it, the better the treatment outcomes are. This isn't something that we've performed particularly well on in the past. As you can see from the graph, the red dots there show that Staffordshire was above the national average for a number of years, but that's been brought down in the last few years. Again, for a mixture of reasons. We were one of the early adopters of PrEP, which has got a very complicated name, so I won't try and pronounce it. But it's a new intervention to try and prevent people catching HIV. We're one of the early adopters, and that appears to have been successful, and that's going to be continuing indefinitely. And you can see there from the graph that rates of late diagnosis have come down to around the national average, so a good improvement there. Okay, another priority around under 18 conceptions or teenage pregnancies, as they're often known. The blue line is the West Midlands average, the black line is national, Staffordshire is the orange line. And I think this has been a success nationally and locally, that rates of conceptions have almost halved over the last 7 years. We pretty much bang on the national average there. But behaviour amongst young people seems to be changing. Teenagers are more aware of the risks. There's been better education nationally and locally. I think this is a success that we've been a part of over the last decade. Okay. Unfortunately, terminations, and this isn't age-related, this is all age, terminations are on the increase, again, nationally and locally. Again, the same pattern. Black line's the national average, the blue line's Staffordshire. We are slightly below the national average, which is positive, but the trajectory is upwards. And so it's a challenge for us to try and address. One of the key things that we do to try and reduce the number of terminations is to provide long-acting reversible contraception or LARCs. So LARCs are one of the most effective ways of preventing terminations. It's not an area that we've performed particularly well on in the past. Rates were low before the pandemic, and there was a lot of challenges during the pandemic of getting access to LARCs. Obviously, there's an awful lot of pressure on the health system in general and GP practices. We've addressed the backlog. A lot of credit there goes to a number of GPs that really rose to the challenge to help us with that. And we're investing £140,000 over the next year or so to train nurses up across Staffordshire to be able to deliver LARCs. So we should have much more access. People won't need to go to specialist services. They can access the service in the GPs with a lot more staff being able to deliver it. So that should drive up availability and numbers accessing LARCs. Thanks. Okay, the third area for me is lifestyle services. Again, a summary slide that shows a mixed picture. We're performing well in a number of areas, but we have got some challenges, particularly related to obesity and diabetes that's associated with obesity and a whole range of other conditions. Okay, thanks. So you can see the slide there. Again, a national and local challenge. Unfortunately, we are above the national average, and that probably almost certainly reflects levels of obesity in the county that we'll come to in later slides. There is also a recording issue. We are particularly good in Staffordshire at recording diabetes, but I don't think we should use that to be complacent. It's clearly a challenge. It's on the rise, and it reflects those other indicators such as obesity. One thing that we are doing about that, though, is the National Diabetes Prevention Programme. Again, we were an early adopter of this, and we've been really successful over the last year or so of getting people onto the NDPP scheme. It's primarily about targeting people with early signs of developing diabetes. There's a whole range of interventions that we do. It's but mainly about reducing people's weight. On average, people lose about 4.4 kilos, or about 9 pounds in weight on the scheme, and we've been one of the most successful at engaging people in the scheme, and then the conversion of people who are actually accessing the scheme to benefiting from it is high as well. So we're really pleased with the NDPP, but there's clearly a big challenge to address diabetes over the next decade or so. And that slide really just summarises the situation in terms of excess weights in adults. 2 out of 3 adults in Staffordshire are overweight, marginally above the English average of 63%. And then you can see the 8 districts and boroughs. There's a fair amount of variability across the area, but I think it's safe to say it's a challenge in every part of the county. There's a whole bunch of associated issues with that, not just diabetes, but cardiovascular conditions, asthma, and a whole range of other medical complications. Obesity is probably one of our number one priorities as the public health team over the next few years. It's not something that's got quick fixes. I think there's some similarities to smoking. As you're probably aware, smoking rates in the 1980s were an awful lot higher than they are now. And we've seen that success of numbers of smokers coming down over the last 20, 30, 40 years, and deaths associated with smoking, as we'll come on to in a minute, have dropped. We've got a similar challenge around obesity. We're not going to address this in the next 2 or 3 years. We need that 10, 20-year programme with local initiatives, national initiatives to try and address it. But this is a big area of work for us, and I think we'll say a little bit more, because we're doing it across adults and young people, so there's a bit more detail a little bit later on about what we're doing about it. The weight management service that we've got has really picked up over the last year or so. You can see from the figures there that only 630 people accessed the service in 2021, but so far this year, the first 6 months of this year, we've already seen 1,700 people access the service, so nearly 3 times the number of the previous year in the first 6 months. And that partly reflects the investment that we've had in the service. But not only are we engaging people, the conversion rate, again, the number of people who are actually successful in the service, 58% is way above the national target. National target of 32%, so we're performing really well on the weight management service. Obviously, services aren't the only answer to this. We can't get everybody who is overweight through a service, but we are having some success with some of the most challenged people. Okay. Smoking, as mentioned previously, is a success story, again, nationally and locally. The number of people who are smoking is gradually reducing, and the number of people who are dying from smoking-related conditions is reducing. 10% reduction in Staffordshire in the last 2 years, a little bit higher than the national average of 8%. But it's still a challenge, but I think it demonstrates what good public health can achieve over a period of time. And as mentioned previously, this is the sort of approach we've got to apply to obesity in other areas. Okay, that's it from me.
Okay, so the two areas that I'm going to pick up are sort of slightly different from your traditional, I suppose, public health programmes that Tony sort of shared with you in terms of sort of services. So if I start with the Supportive Communities programme, and it's probably fair to say this programme, actually we had the Cabinet sign-off of this March 2020, so just as we entered the lockdown, so just before then. And actually I think the programme, as I'll share with you, sort of, I suppose, bore testament in terms of the approach that we actually had agreement to sign off for. So it's very much about how we can develop a prevention and early intervention process and support to adult social care. We know that adult social care and the demand for adult social care was rising pre-COVID, and we've obviously seen some of the issues COVID has resulted in that. So in essence, this is just sort of a bit of a reminder of what the Supportive Communities programme is about. It's about high quality information, advice and guidance, about providing those options for better self-help, and also about community-based support, and say with a focus about reducing the need for people to access formal adult social care. And I think it's worth sort of noting that, COVID-19, as we know, has had a significant impact on people receiving and providing adult social care. We've seen a demand for new assessments. I think only today on the news, there was, that's a national issue, recognising sort of demand for self-assessment, assessments is up and is obviously causing sort of issues. And also we have some issues in terms of the workforce. My computer's just, are you okay to move on? Thank you. So the next slide is just to give you a bit of a overall sort of data on this, which is we're seeing the demand for adult social care has continued to increase. Workforce shortages and other challenges are obviously impacting on capacity into adult social care, as I've just referred to. And I say the other areas I'll touch on is in terms of some of the issues that we see in terms of fuel poverty. So 44,500 homes in Staffordshire are suffering with fuel poverty. That's similar to England and stable in the last 5 years. But it's also unequal across the county. We have an ageing population, and the loss of comfort and independence in life and increase in winter pressure means there's demand for health and social care. So that's just sort of giving you a bit of a highlight. I think this is a really nice slide to just say, well, what are those issues? Why are people coming to the county council and other public sector for help and advice? And what we sort of know from our data and insights that we would suggest about 75% of the reasons why people are asking for help and support could be provided through different means, through families, friends, support, etc. So this is just from our data where we were finding the demand coming in. I say a lot of this was sort of low-level support that could be supported elsewhere. Claire's already sort of touched on issues around loneliness and social isolation. We know that's one of the key sort of tipping points for people requiring and asking for help. And in essence, that was part of what the Supportive Communities programme was really wanting to do, is how can we address and how can we identify those activities and those mechanisms within local communities through support from friends and families that can actually help people before they require that a service, hence that in early intervention and prevention. So in terms of the programme, as I say, we actually had sign-off to deliver the prevention programme, the Supportive Communities programme, just say before COVID really sort of hit. But this gives you sort of some of the outcomes that we have actually seen. And as I say, our focus over the last sort of 12 and 18 months, unsurprisingly, has been about really getting that information, advice and guidance out to people in a very different way. So what we've certainly our relaunched and refreshed sort of web-based digital offer has seen an absolutely phenomenal number of hits, 132% increase over on the previous year. Now, as we can say, that's probably a lot to do with people requiring to get information advice through different means. But I think what's really, really important to note is the amount of work we had put into those refreshed web pages. They are much easier to navigate. They are easier for people to find the right support and help. So I'm also hopeful that's part of the testament in terms of seeing that increase as well. We also launched a number of new programmes online and the self-help support through our Happy at Home. Just if I can just give you an indicator, so this time last year we launched that website, and just within sort of a month we actually received just under 10,000 sort of hits on that site, and we actually received an awful lot of positive feedback, because that was not only about giving information about what was out there and available to help you stay independent, it was also directing you to where you could actually purchase those items or get hold of those items yourself. So that was a really successful campaign. And then some of the other sort of advice has been through our health apps. That links very much into some of that healthy lifestyle behaviour as well. And just to give you an indication that in terms of the listings that we have, in terms of the support that's available in the community, we have over 4,500 listings. Just 2,500 are relating to adults and communities, and about 1,500 about places to go and things to do. Now, if you actually compare this to other websites, we have a lot more information and accessible compared to our counterparts. And some of that is in part to the partnership that we have with the voluntary sector, who really help us to make sure that that information is up to date as we can. Some of the other highlights in there, as what you'd expect, is that volunteering with COVID, we definitely saw a big increase. Internally, this is information that you'll have seen before. Our own sort of staff, we had about 1,300 staff sort of offer support and help through the COVID response. And the VCSC sector, so particularly through Support Staffordshire, they saw an additional 2,000 volunteers come in, and they did actually manage to get about 78% of those into volunteering activities, and that's without those other volunteers. So you'll know through the NHS there are a number of volunteers there. Some of the other highlights for last year, if I could say, we saw through the voluntary sector, we worked very closely with Support Staffordshire. They're our infrastructure support organisation. They have managed to get just 4.5 million additional funding to local voluntary sector organisations. Some of that would have been our own grants, but actually some of those would have been extra as well. So that's actually really, really positive. And actually over the last few years, they've managed to get quite a lot of resources out to our local communities, providing some of those real local activities that are going to help us in terms of the adult social care demand. We also launched community help points. This was community help points are a face-to-face support in terms of information, advice and guidance. Of course, because of COVID, it couldn't be as face-to-face as we would have liked, but it provides an alternative to a digital support. So it is telephone support, also support through libraries and other community organisations as they were able to open.
I'm sorry to interrupt. Could we use the next couple of minutes just to wrap up this presentation? I don't know how much more you've got.
Yeah, it's fine.
Otherwise, we won't get a chance to ask you questions, and that was probably the purpose of inviting you today.
Okay, so the next one, I'll just focus a little bit on Staffordshire Home Warms. So, I've already touched on sort of the need in terms of this area, in terms of fuel poverty. And the other one here is obviously is focusing on establishing some savings in terms of the cold-related falls, etc. This is just a really helpful slide to show you how much sort of resource we've managed to bring into Staffordshire to help with this programme, number of programmes, and then this is very quickly, it's just, that's a really nice slide which talks about the installations, etc. So obviously just sort of focusing on a really sort of focused effort in terms of fuel poverty. So really successful because of the partnership agenda. It's worth saying it's Staffordshire County Council, but we work very closely with other organisations, and I think we really need to sort of recognise sort of Eon and Beat the Cold in terms of their delivery, particularly through COVID as well, where it was really quite tricky. Okay, so they were sort of the areas that I was going to touch on. I don't know if we have time to move into the sort of the children's public health.
Perfect. I was going to invite Mark just to say a few words, unless...
Thank you, Mr. Chairman. Karen Coker, who was coming to do a presentation, unfortunately can't because she's unwell. I've tried to get someone else while I've been sitting here, and Natasha Moody, who would have come, is on holiday, so she's not able. So I'm not going to be able to, or officers here are not going to be able to answer questions in detail around children's public health. But happy to stay and see what we can do, or happy to rearrange so that we can bring children's public health in itself at another meeting when I can have Karen and or Natasha here to support. You'd certainly probably get more value if we did that. But obviously a matter entirely for yourself and your committee.
Thank you, Mark, and thank you for the suggestion. So, Mark's made a suggestion there. I think, you know, the first three presenters, you know, have given us a lot to go at, and it's an important area for the County Council and for our communities. So, what would committee like to do? Keith?
Yeah, I think it would be worth maybe bringing it to a future meeting if we can, just as a smaller item. There's quite a lot of children's mental health and everything within it as well, and that's part of the mental health project that we've been looking at and we're going to do a work programme on anyway. So it might be nice to maybe bring it into that process and have a bit more time to look at it, you know.
Thank you. Other thoughts, Anne?
Yeah, I totally agree with Keith and your comments, Chairman, that we should bring it to another meeting. Most important.
Thank you. Are we all in agreement with that proposal? Okay, I think we're all in agreement. And Mark, please, can you pass back our comments that it isn't that we don't want to hear what you've got to say, quite the opposite. That doesn't mean we will be a vicious or a argumentative committee. It just means that we will have more time to understand better what you're doing. And on the flip side of that, that does mean we get more chance to understand what Claire, Tilly and Tony have been talking about as well. So is that okay? I know you've made a special journey in this morning through snow and locusts and all sorts of other things. Is that okay with you?
Absolutely. So if I could be excused, that would be fine, and I'll speak to officers and so they're prepared for whenever you want to see them again.
Absolutely, thank you. Brilliant. So given... just let me ask one other question. Tilly, were you happy that you'd covered in sufficient detail the bits you wanted to cover?
I'm sure there'll be questions that come through that I can sort of elaborate.
Perfect, thank you. So, Angela.
Thank you, Chairman. I think we've all got a lot to play with the health situation, you know, as councillors and everyone else. But my question relates to the termination of pregnancies, really. And I should imagine some of them are young mums as well. And I would ask, what help, because it will affect their mental health as well. So what help do we give these mums, you know, that's had termination of pregnancy for whatever reason? You know, there must be some sort of impact on their mental health state. So that's my first question. I'll come back on the others. I'll give other people a chance.
Thanks, Chair. I'm fairly confident that there is support for people who had terminations and referrals into services. I'd like to be able to check the details of that before saying for certain and bring that back if that's possible.
Perfect. And did you have a second question? Johnny McMahon.
It's in large part the reason, not solely, but in large part the reason why we concentrated in the presentation so much on the LARCs, the long-acting reversible contraception. Because with that in situ, those who have a more chaotic life and find themselves requiring terminations, and 50% of them are multiple terminations, won't require that service. So we're going to, so that preempts the need for counselling and all the rest of it, and going through the trauma of getting an abortion in the first place.
Claire, I will come back to you, Anne, but Claire.
Sorry, just really quickly to add to that. So the termination service is commissioned by the CCG, so we are working very closely with them, as Tony said, and I'm really confident that wraparound support is available, but it's not a direct service that we commission, but obviously we do have a role in terms of trying to make sure long-acting reversible contraceptions are part of that, but we can go away and have that conversation with the CCG.
Can you provide a written answer just to Deb Breeden, please? And I know I can hear Julia shouting in the background, just to remind me that the Cabinet have just taken a decision on the whole of that sexual health commissioning piece, and part of that has been an added investment in LARCs as well. I'm sure she'd be shouting at me if I didn't say that. Anne, did you just want to come back on?
Can I come back with a totally different question, Chairman, please? Yeah, fine.
Yes, and then I'll go to Paul Northcote.
I'd like to ask Tony, actually, you know, we talk about drugs, and drugs has been on the increase in Stafford, well, in Stafford, to my knowledge, for the last 30 years. We talk about county lines, and county lines has been prevalent in the town for, as I say, 30 years. But how closely do we work, talking about deaths from drugs, and how closely do we work with the police on this issue? Because of the, you know, criminality that's involved as well. Thank you, Chair.
Thanks, Chair. We do an awful lot of work directly with the police and other criminal justice agencies. Some of it's funded through the Police and Crime Commissioner. We've got drug and alcohol workers across the criminal justice system to try and identify people in the police stations, in courts, in prisons. Some of that has been hampered by the pandemic. We can't get into prisons in the same way that we used to. Obviously, there's a big backlog in the court system, but we do have people in the custody suites. We also have a scheme called, the police have a scheme called Integrated Offender Management that includes drug and alcohol services as part of that partnership. And the police and criminal justice agencies have always been really strong at working in partnership. We do an awful lot with them as part of our strategic development. They're part of all our planning groups. They're getting involved in a lot of what we do around drug-related deaths. It's often police officers that are the first person at the scene and play a big part in supporting our efforts around deaths. So I think the partnership with the criminal justice system is one of the strengths of what we've got in Staffordshire. As I said, part of that's down to the funding that the Police and Crime Commissioner provides. And the way that the criminal justice agencies work, I think they've got a real tradition of working in partnership. So I think that is a particular strength of what we do.
You want to come back, Anne?
Yes, I find that quite interesting. I'm really concerned about, you know, people taking drugs and dying from that, and just what we can do to help. Yeah, thank you. I've got another question, but I'll...
Thank you. Paul Northcote.
Thank you, Mr. Chair, and thank you for that answer about the criminal justice system. That was going to be my first question. The second question I've got relates to sexual health. Now, we know that young people have a very chaotic lifestyle, and trying to encapsulate that and get them to engage is extremely difficult. And I've read in the report there that the walk-in clinics have been cancelled because of COVID and the move over to appointment systems. But could you give the assurance that where they exist, that the walk-in clinics are protected and are going to resume? And furthermore, will there be any increase in this? Because they're extremely popular, particularly with young people with chaotic lives that they engage, and they do it at the last minute and just want to walk in rather than going through an appointment system, which they find quite intimidating. Thank you very much.
Yes, as the COVID restrictions are easing, we absolutely want to do everything we can to try and encourage access to the services. So the walk-in services will be maintained as much as possible. The new tender that was recently signed off will mean that we can do more from April 22 onwards. So we were hoping to expand a whole range of different things that we're doing around sexual health, and as you identify, access, making it easy for people to access, making sure that there isn't the stigma, there isn't those difficulties around being identified. So absolutely we want to maintain and increase those walk-in clinics.
Paul? Let me go to Keith then.
Thank you, Chair. Two questions. First one is about diabetes. I should declare an interest. I'm a diabetic. My experience has been almost the reverse of what you reported. There has been a distinct lack of any groups available, of any assistance. I've been told on a repeated basis now for over 4 years that I have to do it myself in terms of being able to monitor and even finding out what it is that makes me a diabetic. So there is a variance obviously across the board, so I'd like to try and make sure that in future that doesn't exist, and that there is a far more sort of collective approach across the whole of Staffordshire, because certainly I've been trying to find how to sort this out myself with very little support from the NHS. So I don't know, you'll make a comment on that first. Thank you.
I suppose the first thing to say is that the treatment for diabetes is a responsibility of the CCGs and the NHS rather than ourselves. Our role is around prevention. But a key part of what we're doing around obesity, weight management, and the wider associated issues is to try and work much better in partnership. Some of the slides that Karen was going to cover around Better Health Staffordshire is our programme around obesity. We're doing across all ages. What we found is that there's an awful lot of things out there that can contribute towards preventing diabetes or reducing people's weight, but it isn't particularly well coordinated. So we don't have a lack in Staffordshire of opportunities for people to exercise or to lose weight. But there's been very little strategic infrastructure around that. There's been very little partnership working. There hasn't been a clear set of objectives and priorities. And that's what we're trying to address through the Better Health Staffordshire programme. We're looking to develop partnerships in each of the 8 districts and boroughs to bring health, to bring the districts, fire, the community, everyone who is interested around addressing obesity and then the associated issues such as diabetes. So I think you're right that there's been a lack of partnership working, and we are trying to address that going forward.
Thank you, Chair. I was going to suggest that if we do bring it up as one of the options under item 6 later in the agenda, to look at boroughs and districts and looking at ways that we may be able to do this in a better way than is at the moment. Not just because I'm a diabetic, but just in general across the whole thing. And that takes me on to my next question quite neatly, which is to do with sportive communities. Obviously, Tilly knows all the work that we've been doing.
Just before you do that, can I just, I'm somewhat surprised that Johnny McMahon didn't indicate on this, because I remember having many conversations about obesity and diabetes and the link, and the, you know, particularly one of the key elements within preventative.
Happy to engage, Chair.
Are you okay with that, Keith? Thank you.
I thought the thrust of Keith's question was more, once I'm diagnosed, I'm struggling. And I fully understand that. I can't hear you.
So even before I was diagnosed, there was no support to be able to help us to try and reduce that likelihood of me becoming a diabetic. Whether there's something else in the background, I don't know. But effectively, I found it right the way across the board, even before I was diagnosed as a diabetic, not just when I became diagnosed as a diabetic. Okay.
The issue about diabetes is principally because we're not active enough, and the quality of our food consumption isn't what it should be. And that's exactly what the new Everyone Health program is all about. It's all about taking a whole systems place-based approach. And there's a principle, I think, in some of the stuff that we've been hearing here, and that's that we have a public health burden. And what we're hearing is how we address the burden by improving people's lives, rather than trying to improve the burden in the first place and reducing it. And that's what this program is all about. And I think, we should use the weight challenge as a starter, because it's clearly, from an epidemiological point of view, it's what's staring us in the face as being pretty difficult. But if the whole system place-based approach works for that, I think we should consider the whole system place-based approach for many other aspects of public health. So we're not addressing the burden, we're reducing the burden.
Thank you, and sorry to put you on the spot, Johnny. Keith.
It's okay. But it does add even more to what I was about to say next, which is the supportive communities on concept. The place-based approach is fine. The problem is that people like myself will fall through the network. That's the point I've tried to make, is that it's not consistent across the county. And I don't think we've got the resources to be able to do that. It's been quite clear that we don't have the resources to do that place-based approach across the whole county. So there will be great big holes within that whole approach. So my point is that I would like to see the supportive communities, community help points and everything else being transferred across into the voluntary sector, which is what we've been talking about at previous meetings, etc., etc. And just to support what I'm saying at the moment is that obviously this affects the healthy lifestyles, which is what we're on about at the moment. We're trying to increase the life expectancy, not decrease life expectancy, which seems to be happening at the moment as well. The activity levels of people aren't as sufficient at the moment and don't go across to the NHS social prescribing system that's in place at the moment, because again, it's more or less targeted in places. So I do think that the whole element of this is that if you're going to make this supportive communities and everything else place-based approach, there has to be something different in what I refer to as the supportive communities across the rest of the county. And if we don't recognise that and don't try and do something like that, I know that there's training of other people and everything else on the agenda as well. But I think we have to move very quickly on this, otherwise we're going to lose all the volunteers and everything else that's been going on very well out of those areas that aren't place-based approach, and talk about towns, villages and everything across the whole of the county. I know it's a bit of a, I'm not trying to be negative about what you've been doing at the moment. What I'm trying to get across is that we need to move on this. If we don't move on this, these figures are going to keep going south. And I don't think that that's what we really want within our own health structure. I know that we don't control the NHS, and I know that we don't control many other things that we do here, but if there's our people who are wanting to take this on and wanting to start being understand this, why not train up some of the voluntary-based people out there at the moment, expand the number of those places out there? Because looking at this piece of paperwork, I've gone through at least 10 or 12 of these figures and these numbers out here, and they all coordinate to that. If this has got to be done far quicker than it's being planned at the moment. I think that's my comment. Okay, I'll stop there. I could carry on whittering on for ages, but anyway, right, thanks.
Johnny, I think indicated first, and then on to Tilly, please.
This is not just about place; it's a whole system, place-based approach, and I think the whole system bit is really important, because we can't just rely on people to change the way they live. There has to be systems in place, and the environment has to be in place, whereby it becomes more straightforward for people to change the way they live. Active transport being one of the most obvious examples. Alternatives to fast food in many of our towns is another example. That's why it takes a whole systems approach. And I take on board your piece about having to move with some degree of pace. And we will be as quick as we can over this. But these strategic approaches can't be endorsed overnight. It takes a lot of effort, but we will keep our foot on the accelerator. But it doesn't happen overnight.
Tilly first.
I think one of the things that we certainly sort of aim to do is almost a bit of a dual approach. So Keith and I had a very brief conversation just beforehand, and I know there's always the focus, like why my area isn't the focus at this point, and that's the whole reason in terms of the supportive community programme. There's something about that population level information, advice and guidance through a range of that's accessible to anybody and everybody now. The voluntary community sector that we already commission, again, they have reach right across every area, and so it's not about us as county council officers necessarily doing all this, it's how we engage with some of those. That links to what Johnny's saying about that whole system. So, you know, Support Staffordshire have reach practically everywhere. We have parish councils. There's probably a number of you here who may sort of be parish councils as well. That's an area that we as officers are very keen to sort of link in with, work with, because we can't do it on our own. It's about that whole system and all the parts of it. So I think there's that area. And I think we also do have to remember, and I do take on board what Keith's saying, but to make that impact, we do know from data where our, I hate to call them hotspots are. In public health, we talk about 52 local super output areas, and it doesn't matter which data you look at, whether it's sexual health, whether it's obesity, whether it's loneliness and social isolation, whether it's claimants, they will be the areas that we know are going to be the areas. So hence why we will tend to sort of have a bit of a focus in terms of those hotspots initially. It doesn't mean we won't roll out, but going about that pace, we need to start somewhere, and we need to start somewhere quickly in those specific areas.
Thank you, Keith.
Yes, I'm not trying to undermine or criticise what's been going on at the moment. What I'm trying to say is that I think a different approach needs to be done for the rest of the county. That's my point. I don't think we can put the resource, because we don't have it, into the same way that we're doing at the moment. And I think that there does need to be a slight change of direction and everything else in relation to the priorities that we're doing at the moment outside those hotspot areas. And I just think that there is a chance to do that now, from my own background as a parish councillor, district councillor, and the fact that we've got something that districts can start working and getting their teeth into as well. I do think there's an opportunity now to do it as we come out of the pandemic, and I don't think we should not look at that with whatever minimum resource that could be allowed for us to do that. That's what I'm saying at the moment. And just to reiterate what I'm talking about the whole strategy concept, is that we're now looking at buses. You're going to come to Prosperous this afternoon. I'm here all day doing the Prosperous Committee. And we're looking at the Bus Inquiry Day. Now, that doesn't appear on subject. It might be related, but it does. If those people are the same people that can't access all these other activities and excesses that are going on because there's no bus services or no way of them getting to and from these activities, then it does relate directly to the overall strategies of how these things might link together. I know it's across portfolio, but nonetheless I do think it's something that we all need to be aware of, and it's same goes to access to mental health activities and everything else. It all relates together. That's all my point. Thank you.
I guess in some ways the point you're making is who owns public health. Does anyone want, Johnny, do you want to just add a line to that?
It's exactly what a whole systems approach means.
Thank you, Keith. Useful. Charlotte.
Thank you, Chair. First of all, I was interested in the figure of 6.3 million new investment in public health, when, of course, the public health grant, as I understand it, has reduced by 25% since 2015. So I was wondering where that new investment has come from. Secondly, I think it's paragraph 46, I was interested to know what the backlog for new assessments for social care is as demand is rising. Did ask that of the leader of the council in corporate review the other day, but I haven't yet had a response. And thirdly, on healthy lifestyles, you talk about everyone health having a good performance. Now, for interest's sake, I actually put myself through some of their sessions. Admittedly, I did increase my weight. I bulked up my weight another couple of stone, so I was eligible, and went through their sessions, and I was very impressed by what they did, some of the sessions and so on. And, the staff were very good. But the problem is that this was based in the most deprived part of Leek, and it didn't survive. It was moved. And that brings me to the question about how far does Everyone Health actually get to the most deprived communities, where perhaps the most vulnerable potential users are, and what are you doing to track their performance in the more deprived communities where probably obesity, smoking and other issues are uppermost. Thank you.
Tilly, is that with... Tony?
Yeah, I can address the first and the third question. I think Tilly will take the second one. The majority of the 6.2 million has been secured for drug and alcohol services. We get some investment from the Police and Crime Commissioner. We get some investment from the CCG locally. We get around £2 million, I think, off the top of my head, from DCMS, Department of Culture, Media and Sport, although I think they've changed the title in recent weeks. For the child safeguarding programme that we have, we provide some very intensive services for families who are on the cusp of the children being taken into care. We provide a real high quality service that supports the families and has got fabulous outcomes in terms of reducing numbers of children who escalate into the care, and we save a huge amount of money from that. So that's a big chunk of investment that we get from central government. We also get a fairly substantial investment from what is called IPS, intensive placement support for employment for people who are recovering from drug and alcohol problems. Traditional employment services are very much about getting people job ready in inverted commas around interview skills and things, which aren't particularly successful with the chaotic nature of people with drug and alcohol problems. The IPS scheme works to find jobs for people, get them in the job and support them whilst actually in the job. And that's been really successful. It's something that we've learned from the mental health world. We were one of 8 areas to secure investment for that nationally. It's now been rolled out into other areas and expanded, so it's been a real success story. There's other little bits and pieces of investment that we get from all over the place. A big part of our job as a team is to try and identify areas where we can secure new investment, partly, as you say, to reflect the past reductions in the national grant, although that has increased over the last couple of years, and the announcement in the spending review looks like it's going to stay at least what it is. So we're in a reasonably secure position financially.
Would it be possible to have those figures?
Absolutely, yeah.
Thank you.
The last question, sorry, around Everyone Health. Thanks for the positive things that you've said about the service. The service is targeted at the 52 LSOAs, local super output areas, and then we use a lot of jargon in our services. So Everyone Health is targeted at those areas, again, to try and address the health inequalities that we've got in Staffordshire. So in terms of leak, I assume that it was targeting the Hargate estate. If it's been moved, I suspect that was probably to do with COVID restrictions.
No, it happened long before then.
Happened before then. Again, I'd need to go back and get the detail, but the service will be targeting the people who live in that area. If it's been moved geographically in terms of delivery, I'd need to double check the details, but it will definitely be targeting the residents of the most deprived areas.
Happy to see a written response. Just let me get Tilly to pick up the other question, and then I'll come to you, Johnny.
It was your second point around adult social care. I can't give you the figure. I think you were saying you're still waiting for that. I suppose what I can sort of share with you is that when we first looked at designed the Supportive Communities programme, the number of calls that went into Staffordshire Cares, which is, as you know, it's often described as the front door into services, was around 5,500 calls per month. And that sort of has recently gone up to nearer to sort of 7,000 to 8,000 per month. So in some ways, it's no surprise that there will be more sort of assessments from that. But however, what we do know is that still there will be a number of those calls that go through that we should be trying to divert some of that level of support and help. One of the things we are working with in terms of our health and social care colleagues who are obviously trying to sort of meets the assessments and delivers sort of statutory assessments, is working with them to look if there's anything else that we can do through the Supportive Communities programme. Some of our voluntary sector organisations, you may have heard anchor organisations mentioned before, where they are willing, like they did with COVID, to actually step in and take on board some of that level of help and support. It won't be the real statutory end, but some of that lower level stuff, such as helping, making sure people have got food, their houses are clean, etc. So we are looking at how we can actually sort of build in some of that support. The other one, just very briefly to mention, it sort of goes back to one of Keith's points, is one of the things that we are certainly doing a lot more work in is around such a strength-based work, and another terminology, you hear place-based, you hear strength-based, but this is very much about sort of recognising two angles. One, in terms of our staff, feeling really confident in terms of the training that they have, that actually the support is out there, having those real strength-based conversations to actually help people sort of recognise you don't always need a service. Actually, what can you do for yourself? How can you actually how can you sort of develop some of those skills yourself? And I think the other one is definitely in terms of our voluntary and community sector. So Keith, I think your point was really valid. And one of the things that we are certainly sort of linking in with the voluntary sector is trying to get that training out much wider, because it's there, it's available, it's online, but also some of the face-to-face stuff. Sorry, it was a bit of answering that previous question as well.
I'm going to go to Johnny, and then I've got Julia online, then I'll come back to you, Charlotte.
Thank you, Chair. As regards the wait for home care, I can't give you a number. Julia may have a number that I can't give you, but what I can say is that we're going, that the difficulty is there's been unprecedented numbers for home care, largely because people find being in a care home less attractive, as do the relatives. And you can see that in the bed occupancy rate in care homes. And also the fact that the employment market is so strong at the moment, people are looking elsewhere for work, which one can fully understand. In order to pay the home care staff £1 more per hour, it would cost the county council £2.5 million. So it's a difficult piece. We have been given 2.8 million, I believe it is, from the NHS in order to encourage staff to stay over winter at any rate. And we're looking at a lot of really quite innovative approaches in order to have it set as a career in people's minds. And it's not just something where you look after folk who are incontinent and stuff like that, but an actual career in conjunction with the NHS, making it sort of an NVQ type thing, all that sort of stuff we're looking into. And there's a whole load of other avenues which we are looking into, which I wouldn't want to set hairs running at this stage until we know that they're feasible. In terms of Everyone Health, their contract is due for renewal a rather opportune time, which is March 23. So therefore, we will have to re-procure the whole thing next year. The revised JSNA, which Claire's very kindly doing, will look at the post-COVID health burden in our communities. And that's it. So the timing is perfect in order to use that, which we're looking at the Health and Wellbeing Board in December, in order for that to feed in to exactly how we can do the Everyone Health type public health bits in a way that addresses the communities as a whole and the health disparities with the local super output areas. I'm finished.
Thanks, Johnny. Before I bring Julian, I just will mention that the agenda for the January meeting does cover care homes, and I would expect us to quietly meander into home care off that element. So, Julia, I hope that hasn't ruined your answer.
Sorry, can I just come back quickly? Okay.
Oh, thank you very much, Chairman. Yes, what I was going to add to what Johnny has already said is that Charlotte is absolutely right. There is a waiting list for social care assessments that we are managing to ensure that we minimise the risks to people requiring care packages. And there's a process of continuous assessment to make sure that happens. I haven't got the up-to-date figures, so I think, Chairman, it would probably be helpful if I could arrange for a written response to Charlotte's question that then can be circulated to all members as to what the current backlog is. It changes from week to week. A lot of effort has been made and additional resources into making sure that there's a greater amount of staff hours available to address the demand at the front door. The last figures I had were we were getting 7,900 approaches per month, which is a significant increase. That, as I say, there's a lot of work that's been done to address that front door demand, but also to ensure that subsequent assessments are done as quickly as possible. So if you would allow me, Chairman, I will arrange for a written response to be sent to you for your committee members.
I'm sure we'd appreciate that. Charlotte?
Yeah, just to come back on what Johnny was saying, I absolutely agree that, you know, it's very difficult to pay social carers more money, but that's completely outrageous in the sense that, unfortunately, people tend to be valued on the basis of how much they're paid. And actually, social carers are not valued despite everything we've been through in the last 18 months. And the fact that the County Council cannot afford to pay them a measly £1 an hour more just demonstrates how topsy-turvy this world is that we don't value those carers.
We are slightly off subject.
And the government doesn't give us the money. But the other thing I wanted to raise as well on Everyone Health, I think the issue there is not that they don't do an excellent service, but you don't get to the people. You know, you don't get people off the streets to come to their sessions. And that was the problem in Leek. And I wondered whether we still did exercise on prescription by GPs, because people do tend to go to their GP rather than necessarily going to one of these healthy lifestyle issues. And it's possible that a GP might persuade someone to take some gentle exercise in the local community centre or gym rather than maybe getting them across the threshold at Everyone Health.
I think that was probably about a point of access. So does someone just pick up Charlotte's last point, please? Not the first point, because we'll pick that up separately in a different forum.
We're doing a lot in order to engage with primary care, because GPs do see people. That's the point. And in order to use that to enhance both statutory and the community offer, we're doing it as a pilot first in the East, largely because the East PCN, run by a gentleman called Dr. David Atherton, is so hugely enthusiastic, and he's got a very enthusiastic group. Once we know that this pilot works, and I've got every confidence it will do, actually, once we know it's running, even before we see the outputs, once we know it running, we will explain that to the other PCNs, because I think it's a no-brainer. It's a no-brainer.
Thank you. Richard Cox.
Thank you, Chairman. I declare that I'm diabetic as well, type 2. The last 30 years plus. Much of what I was going to say has been answered, so I'm not going to duplicate and I'm not going to request answers. So it more is a comment in the sense that I recognise what was said as important in the disconnection that there is about. And that has been one of the things that I've felt for years, that somewhere along the line there are missing pieces to the jigsaw. And if that can be dealt with as quickly as possible, I think hopefully we might see things improve, particularly around that waste management programme, because I think that actually is where it probably does help. I admit that I suffer with my weight, and it's up and down, it's a yo-yo. I think I did pick up the comment about actually there is a purpose that an individual has a big part in this, but we have to make sure they understand that part and it's embedded then in their lifestyle, because otherwise it's yeah, I understand what you're saying, but then obviously if you lose them, then we're back to square one again. So it's bringing all that through together. But I recognise what you've said, and I thank you for that, because I think that was my key question, and I'm glad it's been answered through the debate. My one question, however, is through drugs and HIV. In terms of the figures that we have, is that the drugs is on an increase, and HIV a similar rate. Are we connected with the two? In many cases, with drug use, with needles and so forth, that HIV is because of that situation, and not just through sexual activities that might transmit HIV.
Tony.
Thanks. And yeah, the transmission of HIV through sharing of needles is a potential issue. Fortunately, in Staffordshire, the rates of transmission for our drug-using clients is very, very low. We do have a successful needle exchange program, so people get free needles. Some of those are provided through the specialist services. Some of them are done through pharmacies. I think it was particularly in Scotland in the early days of the heroin epidemic in the 80s and the rise of HIV. It was one of the key issues, but we are fortunate in Staffordshire that there's very little transmission that way. But it is a risk that we're very mindful of.
Claire, go on, Johnny.
It's just some Scottish history, really, and it depends on the drug habits as well. In Edinburgh, there was a significant HIV problem because they injected. In Glasgow, they did a lot of sniffing, and therefore the HIV thing just didn't happen in Glasgow the way it happened on the East Coast.
We learned an awful lot of lessons from what happened in Edinburgh, and yeah, fortunately, Staffordshire performs pretty well in that area.
And certainly Scotland has not got a great drugs record at all. Claire.
Thank you. It was just a sort of comment really on the point you made about individual lifestyle choices and keeping people engaged and all that kind of stuff. And I guess that really reflects and kind of emphasises the importance of what we've been talking about in terms of this whole systems approach. And I think sometimes that label isn't that meaningful. So I guess just to put that into real terms, really, it's thinking about how we, first of all, capture people as early as possible. So whether that be through a family's approach, so we're teaching children, young people about healthy eating and things like that, as well as their parents at the same time, whether that be in schools, whether that be through the Better Health Staffordshire programme. So we're working with the children, young people's team to make sure that's a whole family approach. And it's also about how we work across different organisations and across our own organisation to make sure we're thinking about health and well-being in all in all the decisions that we make. So, you know, when we're thinking about planning or licensing or access to green open spaces, active transport, all those things that have an impact on helping people make healthier choices, having an environment that's conducive to that healthier lifestyle. And that's really what we mean by that sort of whole systems approach. So although the services are useful and they're an essential part of what we have on offer, they're only ever going to reach a very small proportion of the population because a lot of people just don't want to access supports to sort of lose weight or, you know, stop smoking. All those services tend to reach 5 or 10% of the population in need at any one time. And that's a given across the country. So it's about how we have that as one part of our offer, but actually will have far greater impact on the whole population if we can think of those things in terms of the wider determinants and working more upstream, but also in terms of whole families and whole communities. So I guess just to give you a bit of reassurance in terms of that is how we have thought and are thinking about tackling some of these really, really complex issues. Thanks.
Thank you, and I should probably just mention that Anne's leading piece of work for next year on the wider determinants, which should link into this as a pre-runner. And I think in fairness to Claire, I think there is a bit of inference that there is a role for districts, boroughs, parishes and community champions, community leaders. Richard, is there anything you want to come back on? You're nodding. On that basis, let me bring in Angela.
Thank you very much, Chairman. Right, can I talk about warmer homes, actually? I think a lot of this, and, you know, we're talking about 44,000 plus homes that's, you know, need help. And a lot of these probably are directed to the elderly. And a lot of these elderly do not use computers. So my question really is there any way that we can put leaflets in libraries and places like that, so that, you know, because the elderly do go and pick the library books up and that. So if you can give some information out there, that would be useful. And also, can I pick up, Chairman, on diabetes? Because I remember when I chaired the health at the borough, I tried to push this diabetes subject onto the agenda, and I got knocked back by the officers. This is a county issue, it's not a borough issue, but I do feel that we should put some impact on the borough's health, community and well-being, as it is in Stafford, to do more work on this diabetes subject, because it is very, very, yeah, I mean, you look around this room and see how many people are suffering from it. So I'd like to think we can put more influence on the boroughs to do that. And also, picking up Claire's point, and Philip in the back there will probably know more about it than I do, and this is talking about healthy schools, and we've had a conversation about this, where most schools and healthy schools, we had 200 and something at one bit, Philip, as you've told me, and now I think we've got about 9. So I think, you know, it all starts at that early age, you know, with children and showing them what they should be doing, what they shouldn't. So my question really is, what influence or what work can we do with the schools, please? Thank you, Chair.
It's nice to be told that I'm overweight on the run-up to Christmas, so thank you for that spirit of good cheer. Tilly, before I bring you in, can I just bring in the Cabinet member, please?
Yes, thank you very much, Chairman. A question was asked 20 minutes ago, I think, about who owns public health. Well, public health activity, certainly it's a county council's responsibility, but it's a partnership. We can only do so much. The other vital part of the ingredients is us as individuals. We all know you can nag people to give up smoking, nag people to lose weight, provide them with all the information, but it's only when that individual makes up their own mind that it's something that they need and they want to tackle, does it actually really make a difference. So in terms of who owns public health, it is a partnership between the statutory organisations like ourselves, but that essential ingredients is us as individuals. If I don't want to lose weight, however much availability there is of support, information, I won't lose weight. It only happens when I look at myself and say, I need to lose some weight.
Let me ring in Tilly. Thank you.
I think you made a really valid point there, Anne, in terms of the warmer homes being quite sort of focused around older people. It's not just, it is a bit wider, but the majority will be older people. I think your point around sort of that digital and relying on digital to get information isn't always the best for everybody. So it's a really, really valid point. So I suppose what I can say in terms of the funding that we've received in terms of, you know, fitting sort of boiler heaters, also insulation, etc. They tend to have quite a clear criteria, and certainly in terms of the criteria for accessing the sort of the additional stuff, we can quite target, so we will do leaflet drops, not just sort of, but we'll be very targeted because of some of this, some of the technology. We'll almost know some of the homes that are colder, because you can do some of that infrared stuff as well. So we do leaflet drops. I think the other bit to remember as well is that, yes, libraries are a really important point of picking sort of some of that information up. It's also worth remembering for older people, which is some of the campaigns that we've done, is actually targeting the carers and the families of older people. So it's a bit of a mix and match, some directly to those individuals through doors, but also to sort of their carers and families, because they will be picking up the messages. At the moment, we've got the winter pressures, so we definitely are sort of pushing stuff out into libraries and some of the venues that you've mentioned as well.
Who's going to pick up Anne's point about education and getting into schools, which I think was her point about healthy schools. I don't think it was specifically about healthy schools. I think it was about the principle of education at a young age.
I suspect that's probably a question that's best directed at the children and young people's team when they come back, if that's okay. I just don't think we'll do it justice. We can probably cover some bits, but I think there's probably a lot to be... I mean, there's some bits of that now that are covered by the statutory PSHE and sex and relationships education, but certainly there's much more than that that happens through things like the school nursing programme, which I think we will probably not be able to cover in as much detail as Karen and her team.
Yeah, I think there's a principal point here, which I think more education done at a young age, the better. But I do take the point if you're happy with that, Anne. Do you want to come back on the others?
Yes, I just want to come back on something else while I've got Claire here as well, and knowing that she works with the CCGs. I mean, I had the unfortunate situation a couple of weeks ago that I had to go to the doctor's surgery, and I sat there and I was looking in reception and I'm thinking, okay, COVID is very important, flu is very important at the moment, very important, but there was nothing at all about mental health anywhere in that reception area. So when you go to your meetings and everything, if you could pick that up, that we can help some way the doctors. Yeah, thank you.
I like the point, Anne, but you're slightly off subject again.
I know, I agree, but I just thought, while I think
given that you didn't ask a question, I think we'll just leave that one where it sits, if that's okay. Daniel.
Thank you, Chair. Just like to pick up 2 points. Firstly, declare interest on diabetic and smoker. I'll put that down soon as everyone's
I think we'd all be declaring lots of interest if we went down every bit, but I appreciate your honesty and openness. Thank you.
I just want to pick up something about the conceptions and terminations. Links in a little bit with COVID. There's not so much false information, but a bit of scaremongering going around about the contraceptive pill and that you have to come off it because it's going to give you blood clots. I just want to find out where we're going to pick up the fight back on that misinformation, because we don't want to see these figures shooting up as we're coming out of COVID. I like the fact that at the termination clinics using nice guidelines and nice advice for the larks, which brings me nicely on to the smoking. Now, the prevalence is going down. I'd suggest that that's more of a stigma. There's more stigma put on to smoking, so people are moving away from that. Younger people aren't getting into smoking. But the cessation clinics, nice guidelines suggest that it should be a combination of both behavioural and pharmacological interventions, and I just want to find out why the local authority isn't using that recommendation.
Claire.
Thank you. So on the first point, sorry, I may have misunderstood your question, but was it around where to direct people in terms of getting accurate advice around the risks of the contraceptive pill and or blood clots and or COVID? Okay. So I would suggest just if it's a specific inquiry from an individual, always direct somebody either to their GP or the sexual health service, because either or both of those professionals will be able to give people full and complete information about whatever contraceptive they choose, and also actually sometimes that's a good time to get people in for a long-acting reversible contraception if that's not something they're already using. So that would be always my recommendation if it's a specific individual inquiry.
It's more broader really, not for an individual, but it's being plastered on social media, and I wonder if the county could put something out on their communication side about, yeah, there is a risk, small risk, dependent on what contraceptive you're on, but at the end of the day, it's a small risk, and there are other options available.
Okay, in that case, what I'll probably do is pick that up with our communications colleagues to see if it's anything that they've come across that we can perhaps do something to counteract that, yeah. On the second point, I mean, yes, you're right, smoking is certainly not something that's as popular, I guess, in terms of young people's uptake nowadays, but I think that's absolutely a reflection of 20 or 30 years of really hard concentrated effort from the public health community and wider. So I think that's probably one of the big success stories in terms of how things can be done across a whole system. So it's, you know, been policy change, legislation change, tax increases, advertising bans, point of sale restrictions, all that kind of stuff in combination over a number of years to change the way it's viewed and people's accessibility to it and the availability of it and all those kind of things. So that in itself, I think, is a useful point to note, just because that's, I think, where we need to get to with something like excess weight and obesity. So that's kind of the model, I guess, we need to try and follow. In terms of the Stop Smoking service, it does offer both behavioural support and pharmaceutical support, so medications, either nicotine replacement therapy or medications, as well as behavioural support. So I'm not sure, do you want to add anything to that, Tony?
No, just to support Claire's point, the Everyone Health Service is based on the NICE guidelines, so there shouldn't be anyone who doesn't get the behavioural support alongside the medication. If you've heard reports to the contrary, it's something we can look into.
Thank you. I always have a stat ringing in my ears that 90% of health work is done through GPs. So I think that's it's always a good thing to bear in mind. Just one point, Claire. If you're going to look at the comms piece, could we include the CCG comms as well, just to make sure between the two there isn't a gap? I'm sure you were going to, but thank you. Daniel, is there anything you want to come back on?
Just one more point. Understand about what you've just said about 99% of the time it's at GP level. Their comms to patients is that we don't do cessation anymore, it's the local authority.
Yeah, I mean, I wasn't going to go into the detail, but, you know, the relevant people are around the table if we've got public health with the CCG there. That's probably the point I was going to make. Johnny.
If people just go to a pharmacy and get patches or something, there's a chance that they'll come off it. If they get counselling, there's a chance that they'll come off it. If they have both, they double the likelihood of coming off and staying off. That's why it's in the NICE guidelines. And that's why it's the approach we take.
Thanks. Can I bring in Martin?
Thank you, Chair. Interesting point about the smoking. The figures going down and the aspect of it and everything. But there's a new aspect coming along as well, and this is vaping. And that seems to have taken over a lot of, I think personally, the young starting smokers are now going into vaping, and what impact is that possibly having on young people's health? Because I can't see it being a good thing, to be honest. But
really good point, thank you. Tony.
I'll start, and Claire will probably come back with a much better answer. But yeah, I think there is concern about vaping. I think the consensus in the smoking industry, or the public health response to smoking industry, is that vaping is safer than smoking, but it's not without risks. And so it's not something that we would necessarily encourage in and of itself. But I think you are right in that it has brought those numbers down. But yeah, there potentially are inherent risks with it.
Martin. Oh, sorry, Claire.
Sorry, I was just going to say there's not a lot to add to that, really. I think it is a challenge. The challenge specifically being, as Tony said, the difference between using vaping as a quitting aid, which I think there's a strong argument for saying it's a less harmful substance than smoking, versus young people who may be taking up vaping from scratch, I guess, who haven't already got an addiction to nicotine through cigarettes, but might be just taking up vaping because it's the new cool thing to do. So that's where we've got the big risk, and that's where we would focus all of our sort of preventative messages and sort of comms piece for young people. So that would be our focus, I guess.
I'm just concerned, Chair, that you seem to be swapping one addiction for another, and the amount of young people, particularly just taking up vaping, when I think the whole idea of it was as an aid to get people to quit smoking has been quite dramatic, really, and it's quite concerning.
Can I suggest off the back of that, and we are a health and care committee, that maybe we just ask for some greater data and then decide whether we want to bring this back later on. Is that a sensible suggestion?
Yeah, so on vaping specifically?
I think very specifically on vaping, Martin. if that's okay, maybe just, you know, just some greater data to allow us to make an informed decision as to whether it's something that we should, you know, investigate more thoroughly as part of the committee agenda going forwards. Is that, are we in agreement with that as a suggestion? I'm getting plenty of nods, so I'll take that as a yes. So, Martin, have you got anything? Sorry, Claire, you want to come back?
No, I was just going to say, yeah, we can do that.
Thank you. Martin, is there anything else you want to pick up?
No, that's it. Thank you, Chair.
That's fine. So I'm going to bring this element to a conclusion, with the exception that I'm going to ask two questions, because I've waited very patiently. And they will be on topic, Anne. So we've talked very extensively about the activities that are undertaken within public health. But I'm also mindful that there is a whole range of partners that need to deliver the public health agenda. And we haven't really talked about the process, really. And I would just like to turn our attention to the Health and Wellbeing Board. And I guess my first question is, Health in All Policies was something that was brought to the Health and Wellbeing Board. What is your assessment of the success of Health in All Policies in terms of driving behavioural change? Because if it doesn't drive behavioural change, frankly, we're wasting time. Claire? By the way, it's not a criticism, depending on the answer you give. It's an asking for an open assessment.
Yeah, no, I appreciate that. So that may have been taken before I joined this organisation as an item to the Health and Wellbeing Board, but I think it's a valid question. I think we should continually ask ourselves that in terms of just checking we're doing all that we can do. I think it comes back to the point you made earlier around the fact that it's sort of everyone's business and everyone's responsibility. I think that the key thing to note about sort of public health and health and wellbeing is it's not something that we can achieve or progress on our own, but I think also it's something that everybody can benefit from. So we know that people who have got you know, better health outcomes, for example, are more likely to be in employment, and therefore that will, you know, drive the sort of ambitions in terms of improving the economy and things like that. But equally, we can't make all the changes that need to happen in terms of some of those broader policy and sort of strategic decisions that I referenced earlier around things like planning and licensing and things like that. So I guess what's tricky for us in terms of how we answer that question is we don't know what we don't know. So there could be pockets of really good stuff happening that we aren't necessarily aware of. So I suppose that in itself is a plea to say, you know, if you think there's a role for public health to be involved in something, or you think there's something really good happening that we should be aware of and could support with, tell us, and we will do. I think there's been a bit of a gap for the last 18 months because we haven't been able to really start anything new for obvious reasons. So any spare capacity within the public health team has been diverted towards COVID. And actually, the Health in All Policies agenda was probably one of the areas that I was brought in to lead on. And I had about a week on it and then got sent off to do COVID. But I think we are now in a position where we're starting to pick up some of the stuff that we'd sort of had in its infancy in March last year. So in particular, we're having conversations with some of the colleagues at the county level in terms of how we can do more with public health and planning. Not least in sort of response to things like the early phases of a local plan, but also how we can engage with colleagues in the planning sort of process to make sure anything from the very early decisions through to the end are considering health and wellbeing impacts. So whether that be health impact assessments and sort of tools that can be used to support that, whether it be specific licensing and planning decisions, whether it can be supplementary planning documents around things like fast food takeaways, all those kind of things. So we've started to have those conversations, and that's progressing nicely. I think things like our Warm Homes programme are effectively a sort of health in all policies approach anyway, so it is embedded in most of what we do. It doesn't necessarily always have the label of health in all policies, but as I said earlier, what we try and do with all of our programmes of work, although we do have some direct commissioning sort of service responsibilities, most of the rest of what we do, in fact a lot of what we haven't even talked about today, is that sort of health in all. And I think the policies bit is probably a bit misleading because it's not always policies, it's health, it's just thinking health in everything that we do, I guess, isn't it? On Thursday at the next Health and Wellbeing Board, I'll be presenting the draft strategy. So we've written that in response to previous board meetings, in response to conversations directly with board members, and the new published JSNA that will also be sort of launched on Thursday. And that highlights the key health needs and also health assets, I guess, across the county. And it's also very much about taking that health in all approach, so it cannot be just the responsibility or sort of goal of one organisation. It's got to be across the whole system and indeed across our communities and our residents as well. So that's the sort of approach that's taken within that strategy. So hopefully that will be a little bit of a platform to take it to the next step, I suppose, the next stage.
Thank you, Johnny.
When I was in your position, Chair, I was concerned that it was a tick-box exercise. I think sometimes it's used in a negative sense, and in that point it works. Does this policy make somebody unhealthy? But we want it to be used as a positive way. What can we do in whatever policy it might be to actually enhance health? And I think that's where currently it's missing, because we don't seem to be having that discussion when we look at certain policies. There's something rather, how shall we say, eccentric about the fact that we hold public health here in the County Council, while the widest determinants of health are held by the district and boroughs. The relationship between the district and boroughs and the County Council currently is better than it's ever been, and we need to take full advantage of that, so there's a more joined up approach to health. How we do that is something that we're trying to get our head around at the moment, and we would welcome views.
Thank you. I really welcome both sets of comments. I think that's absolutely spot on. A couple of thoughts. One is, I think there is a huge opportunity with local plan reviews, not just to look at, healthy housing, designing healthy communities, obviously things like flooding, alleviation, climate change, and all of those things. So actually, I do think there is a huge opportunity with that. What concerns me wasn't the County Council's adoption of health and all. Maybe it's the partners' approach, and I guess my concern is if you went to some of those partners and did a cross-section, would there be the same belief, understanding and commitment to the things that we've talked about in here this morning? And I think one of the measures of success for the Health and Wellbeing Board would be to go and do that, and to do an audit and be able to say, actually, this is embedded into everyone's working role, because otherwise people passively ignoring the opportunities that are potentially there. Johnny.
Might I suggest, Chair, that as you have the chairs of the district and borough scrutiny committees, that would be an opportunity to invite them to assure you that that's the case.
I like the recommendation from the floor, albeit not from the committee, but I think it's a good suggestion. I think you've covered my second question, so just let me summarise where I think we've got to today. And I would be grateful to see a copy of the slides so that we can circulate that around committee. But first of all, thank you for a really clear presentation. I thought I was going to be disappointed when I read the papers that there was a complete lack of numbers. So I was really delighted with the clarity of the presentation today and of all the speakers. I appreciate we took longer on the presentation, but I think it was worthwhile and useful. I appreciate the answers to the questions that have come through today. I particularly like some of the discussion about capturing people early and thinking about our environment. We've clearly seen that Staffordshire is a high-performing authority in the areas that we've looked at in terms of numbers, but equally there's a huge opportunity. And that opportunity is to keep each resident away from the front door of health services for as long as possible. And potentially that gap is quite significant when you look at healthy life expectancy versus life expectancy. So I think that's a huge opportunity and one that we must grasp and ensure that our partners grasp on our residents' behalf. I also note that the new JSNA is available and that members may want to go to this week's Health and Wellbeing Board Thursday, 3 o'clock, where there's an agenda item talking about the strategy, and I'm sure that officers and the Cabinet members will reflect back into the Health and Wellbeing Board today's discussion as well. On that basis, I should thank everyone for their input, and I'm sure you will come back in front of us at some stage again, but thank you for everything you've done this morning and you are doing. I'm going to move on to the next. Richard.
Ask, has Jonathan got a set of hard copy papers? Because I'm logged out and it won't let me log back in.
So on that basis, just let me move on to item number 5. You're welcome to stay, you're welcome to go, whatever is the best use of no, not you, Philip. You're here for the duration and Keith's here for the whole day. Right, you can go for a comfort break, you don't need me to break proceedings. Right, I'm going to bring in item number 5, a COVID-19 update, and we have Emily with us, and apologies, Emily, that you've probably been with us an extra hour, but with your permission, I think it was worthwhile. Shall I hand over straight to you?
Thank you, Chair. I'll just share my presentation.
You're very quiet.
Apologies, is that a bit better? Thank you. I should just share my screen. That should now be on screen. Thank you. So Staffordshire currently has a rate of 460.3. Although that is higher than the England and West Midlands rates, we can see that the Staffordshire rate the Staffordshire rate of decline is much steeper overall. Infections are most prevalent in the age groups of 5 to 10 and 11 to 17, which is seen by the orange and the grey line on screen. Hospitalisations overall have remained stable. Deaths are currently below the 2015 to 2019 yearly average for November. This will be a slide that the committee has seen before. However, what's different this time is that we're now able to report on the performance of the booster programme in vaccinations. Currently, we have over 80% of the 65 plus age group who have received their booster jab, 45% of the 60 to 64 age group, 30.9% of the 55 to 59 age group, and 26.4% of the 50 to 54. Boosters were only opened up to the 40 plus age range from last week. And for this session, I've provided 2 further updates, Chair. One is in relation to Omicron. Omicron was declared a variant of concern on the 26th of November. And as of the 27th of November, England had 2 confirmed cases, one located in Brentwood and one in Nottingham. There was a further case reported, however, that person has left the UK. There are new government measures that are in place to control the spread. Most of those centre around travellers in relation to isolation, and depending on what date they've returned as an international traveller to the UK. There are some further additional measures that I'm sure many saw over the weekend, and a summary of those are that all contacts of suspected or confirmed Omicron cases must self-isolate regardless of their vaccination status. Face coverings are to be made compulsory in shops and public transport. However, all hospitality settings will be exempt for now. And the Department for Education is now advising pupils in Year 7 and above as well as school staff and visitors to wear face coverings in communal areas and on public and school transport. However, vaccines remain our best line of defence. All adults who've not yet received their first or second dose, or for those that are eligible for the booster, are strongly being encouraged to come forward and help protect themselves and others. And as an additional measure, 6 million booster jabs will become available over the next 3 weeks. The JCVI are being asked to consider rapidly extending boosters, as well as reducing the gap between the second dose and the booster. And a further update's been prepared around Europe. With regard to the reinfection rates in Europe, countries which have been worst affected seem to be a combination of those with a lower vaccine coverage, those with waning immunity, those with a release of restrictions, and colder weather. And those are my updates, Chair.
Thank you. Really love all those colour charts and things that you do so brilliantly. Thank you. And I see that you've already circulated the slides to us, so I don't need to ask that question. So I'm waiting for an indication from anywhere. Okay. So question for you then. 6 million boosters nationally. Actually, it's presumably England, is it? But over the next 3 weeks. For me, it wouldn't be the issue of availability of jabs, it's the availability of jabbers.
I believe I can confirm a little bit more specifically later, Chair. However, my understanding is that there's been quite a significant drive in training new persons to be able to administer jabs. We've had quite a few volunteers from within Staffordshire County as well that have volunteered to take part in that. So I'll see if I can get some more definitive data for you.
That would be useful, Johnny.
I've offered my services for Saturdays, so I'll be going through the process and I'll be able to advise the committee as to how straightforward it is.
That's very impressive, and thank you for everything that you're doing in that respect. So I've got another question which relates to walk-ins. Anecdotally, some of the walk-in centres where you can arrive without an appointment have been hugely popular, which is always good news. But how do they cope with those spikes in demand so that people aren't standing waiting, for hours, and particularly if they're waiting out in the cold to ensure social distancing? How is that demand management being done, or actually, anecdotally, is that leading to people turning up and being not being able to get the jabs that they want and being disappointed?
We've not heard of many cases of people that have been turned away from the walk-in clinics. They've been really well staffed. They're very flexible and equipped to handle peaks in demand. I know that we have 3 clinics that are booked, that were booked over the weekend that went really well in Tamworth, Cannock and Biddulph. And it's a scheme that's consistently monitored and managed. Personally, I don't see any cause for concern. And I believe we have enough capacity in both resources and venues to accommodate surges in people wanting to take those vaccines.
But implicit, presumably, you'd be suggesting if there were members who were aware of specific areas and concerns, just to raise them directly with yourself or with the CCG lead?
Yes, please.
Thank you. And Angela.
Thank you, Chairman. My question really is, this new variant is a fast-moving beast, and my understanding this morning is on the news there was more up in Scotland, apparently, in the country. So you'll give us the first indication if there is any in Staffordshire as soon as you can.
Absolutely.
Thank you. Thank you.
I've checked we do have access to a line list that specifically relates to variants of concerns and variants that are under investigation. It's something that we can monitor every day. We get that information very, very quickly. As we saw with previous variants, such as Delta, we are well rehearsed in how that works. Currently, as of this morning in Staffordshire, we had no known cases. That data, it relies on genomic testing, which can take up to a week to complete. So that's the picture as of 7 days ago. We had no cases. But it is something that we monitor, and hopefully that provides some reassurance.
Presumably at the same stage you would encourage everyone still to take up their jabs, with or without the South African variant, and equally to take their boosters and flu jabs.
Absolutely. Vaccines is still the absolute best way to fight any new variant.
Johnny McMahon.
It was made clear by a professor of public health in Edinburgh this morning on the radio, forgive me, I can't remember her name, that Omicron or whatever will not render the vaccine useless. It simply won't. It's a question of whether it compromises its efficacy currently. So it may have an effect on that, but irrespective of whether it does or not, the booster and the vaccine program is certainly still worth getting. In fact, it's more important than ever.
Thank you, Johnny. Keith.
Just a very quick one. Again, quite personal, I suppose, in some respects. My daughter had COVID. She wants to get the booster, her jab and everything else. She's 16. The problem being is that she won't have time off to go into the walk-in centres, and is finding it very difficult to book any times elsewhere. So I do think there's a bit of a disconnect about being able to actually go to a vaccine centre as a walk-in potential patient, or whatever you want to call them, and actually being able to deliver that without there being direct input from the schools, or allowing people off to go and get the vaccination if the vaccination hasn't happened in the schools already. So there is a bit of doesn't quite add up for me at the moment on that. Thanks.
Did you want to come back at all on that, Emily?
Excuse me, sorry, I currently have COVID.
Do you need a glass of water?
No, that's fine.
Okay.
Thank you for your feedback. I will take the feedback around being able to access that as a 16-year-old and share that with colleagues to see if there are any changes that can be made or how that can be factored in.
Thanks, that's appreciated. Richard.
Thank you, Chairman. I did raise this at the control board last week. There was a comment made by a fellow Lichfield District Councillor that he made a booking, or he heard of a booking being made through the website for his booster jab, but he's had absolute no contact through his GP service. Now, I have to say, I also got a text message or an email from the main site, and the following morning I got one from my GP. He's saying that isn't the case with his. If he has gone as an action point, I was wondering if you were able to add to anything at this meeting, whether they are talking to each other in that sense. Thank you.
Emily?
I'm not sure if there are any health colleagues on the call today that might be better placed to comment, but I think that would probably be something for health to comment on.
Tracy Shewan is, and she has actually provided me with a written answer already, but given that Tracy's been with us and waited very patiently for her one opportunity, I wouldn't want to steal it from you. So good morning, Tracy, and thank you for joining us this morning.
Good morning, Chair, and thank you. And thank you, Councillor, for raising this issue. I mean, the cohorts 1 to 9 has got 100% coverage from the primary care networks. So we would expect people to be called forward for their eligible boosters via them, but that's cohorts 1 to 9. There is the option, obviously, that your colleague or your colleague's constituent has actually booked through the national booking system. I mean, we do see that people are, they book through the national booking system, can be brought forward. I can check up if there's any particular issue, but when I raised this with the team, they just said cohorts 1 to 9 have that 100% GP sign up, and we do expect them to be called forward. Unless I've got a little bit more detail about the individual, I might not be able to answer him fully, but I'm happy to take that offline and look into it for you.
Thank you, and I will circulate the written responses I've had as well to those questions out of the Local Outbreak Control Board to the board members later on, maybe tomorrow in fairness. Daniel.
Thank you, Chair. Just wanted to speak a little bit about third primary vaccines. Speaking to a few residents from Tamworth, they're still struggling with doctors who don't fully understand about the third primary. I've actually had to get involved with that myself and speak to the GP surgeries to try and explain to them and show them the letters that were sent out to them, I think at the end of September, to explain about the third primary jabs and how they're meant to be implementing them. Just want to try and make sure that if there are further issues around the county that they're explained to the primary care networks again. Thank you.
Feels like a Tracy Shewan question.
Thank you, Councillor. And certainly what we can do is we can send out reminders, because there is regular meetings with the primary care networks around this issue. So if it's an issue that seems to be raising its head, then we'll make sure that that's sent to them in their sort of updates and their meetings. So I will look into that and get that done.
Anything further?
Thank you. Cheers.
Thank you. I'm not seeing any other indications, so I'm going to use Chair's prerogative and ask the last question. We've talked a bit about communications, but can we just talk a bit about some of those hard-to-reach groups, and particularly those people who are pregnant, you know, the cross-section of the hard-to-reach who are pregnant, over 65, vulnerable, long-term health conditions. What are we specifically doing to just ensure that they're having their flu jabs and booster jabs where possible? And because it makes such an important difference for the disease burden.
I will try and keep my answer succinct for you, Chair, but there are many things that we're doing around those groups of people that may be underrepresented or disproportionately impacted, especially those of a vulnerable nature. Some of the activities that we're doing include, we have a specialist way in which we deal with them from a contact tracing point of view. Those cases in those areas, identified postcodes, for example, completely skip the national service and they come straight to Staffordshire for us to deal with personally. We also have a targeted testing plan, so we ensure that there's access to testing much more easily in those physical geographical areas where we think those people are most likely to be. As part of our local outbreak control groups in each of the districts, we work with key stakeholders and partners in those districts, as well with the local councils, police, to discuss the demographic and the makeup of that area and people within that area, so that we can target our communications and other activities. So hopefully that's provided some reassurance.
Thank you, very useful. Johnny McMahon.
We have seen in the county and in England at large pregnant women in ITU with this. And it's just struck me that I don't know what advice is given to them antenatally, because they've got so much to take on board, whether the whole business of getting proper flu and COVID coverage is because that's the time to do it. And I will inquire. I think that's important.
We may have someone on the call, Tracy Shewan, who might be able to give an answer.
Yes, and absolutely, Councillor, it is where the sort of main contact is with people, and we do ask our midwives to do that, and they do support pregnant women. We did just release on Friday, actually, a video that's gone out to the media of a pregnant lady and a member of staff actually supporting the vaccination programme and sending messages. So we're using all sorts of different ways to try and target mums. We know that social media is a key area where a lot of sort of pregnant women get their advice. But yes, we do encourage all midwives to have that conversation to ensure that everybody is appropriately vaccinated, I'll say.
Thank you. And I guess implicitly on what you've just suggested, you would be grateful if members of committee and others could retweet, post, share some of those messages when we see them around our audience of whatever they are, subscribers or residents at least. Richard.
Yeah, just to add to that point about pregnancies. At dinner last night, I heard a friend's friend who's pregnant refusing to obviously have the injections because the midwife had advised her against it. And, you know, I think the messaging then has to somehow, through the system, it's got to be clear that it is something that should be done. But obviously, that's just to help in the debate. Thank you.
That feels like a specific point, and I'm sure Tracy would appreciate any further information that you had, just to help with that education piece, because I'm sure it is a piece about education. Julia.
Thank you, Chairman. I would just guard against specific cases where you don't know the clinical background. There are some people who, for very relevant medical conditions, are recommended not to have the vaccine. They are few and far between. I have a daughter-in-law who's pregnant, but who has problems with blood clots and whatever, and she's been advised not to. So I think we do have to be very careful. The general advice is to get it, but there are some people who quite legitimately have clinical reasons for perhaps being at least more cautious or actually not taking it up.
Absolutely useful contribution. Thank you. I was going to bring this to a close. Richard was going to get the last word, but Keith snuck in. Go on.
Sorry about this, but I should have asked this earlier, but I was out of the room, so apologies for that. In terms of testing, you know, obviously we're still doing really well on the testing rates and all the rest of it. I just wondered, is it because we've got a very high infection rate? Is that partly down to the fact that we're getting more people being tested in Staffordshire? Is there any statistics or anything like that to support that? And does it mean that we are, if you like, quite an active, we have quite an active cohort of people in Staffordshire who are actually quite willing to be tested and to carry on that testing? And is that another reason perhaps why we've got quite a high infection rate still in the county? So I just wondered if anyone could make a comment on that. Thank you.
Emily.
It's a difficult question to answer, and one that we've asked ourselves, if I'm completely honest. We did some analysis a few weeks ago and looked at neighbouring authorities and also comparable authorities across the UK that have similar demographic to us. And what we did see is that we do have one of the highest testing rates, and we do have a high case rate. And we also investigated other factors like school makeups and other characteristics in our district, and we couldn't really make a correlation as to why our case rates were higher than other areas, apart from having this anomalous high testing rate. So I think we could infer that, but I would heavily caveat that statement to say we really have investigated it to scrutinise it, but it is a very difficult statement to scrutinise. Hopefully that makes sense.
Yeah, no, it wasn't so much of saying that. I was just saying, I just think it's good that we have got a very high test rating scenario, and if we are one of the best areas, and then obviously the county council's getting that message out there, and the team is doing really well to be able to keep that test rate and those testing facilities and everything else well ingrained within the population. So I'd like to thank them for doing that, I think would be the phrase, if we can thank anyone from this committee for doing that, because without that information, that means that we've got more chance to control the various variants as and when they might come along. So I do think we need to keep that going. I think that's the phrase. Thanks very much. Cheers.
I think the twin track messaging of testing and vaccination has been the only constant for the last 12 or 18 months, or certainly the last 12 months. And we need to give that message clearly to people and recommend a lateral flow certainly twice a week for trying to catch the virus at the earliest opportunity. I'm going to bring that item to a close now. Emily and Tracy, thank you for your slides and your contribution this morning. I'm sure we will see you again because this virus doesn't seem to want to give up anytime soon. Thank you for everything that you and your respective teams are doing in testing and vaccination purposes. Thank you. Let's move on to item number. You're welcome to stay or go, up to you. I will leave that with you. Item number 6, district and borough health scrutiny activity. Members have the physical reports there, and I note there are a number of meetings over the next few weeks, days and weeks actually. Does anyone want to contribute? Keith.
Thank you, Chair. Yeah, I did bring this up during the first item, or item 4. The idea of maybe trying to integrate a bit more of the community activities in and around at district level, I think is far more common, makes more sense than trying to do it across the whole county in one great big loop, because everyone's got a different background in terms of how rural they are, how many urban areas they might have, how many other areas might need more assistance in terms of any mental health services or anything like that we might be looking at in the future. So I do think that for myself, I will have a word with Barbara, and I do think that we might want to try and produce something that we could then take forward to our district committee in terms of looking at how we can build on the community links and things like that, because I think that's to be the sensible way approach. It was actually agreed with some of the officers today that would be the way forward. I've had another word with Tilly since then, and I do think that that's something that I would like to work on as one of the people that link back to the district, to see if we can build something up that would make sense and also then support all the social care and children's services and everything else that's out there at the moment, but particularly with social care and community groups at the present moment in time. Got some ideas, and I'd like to try and push that if we can. At the district level, if that was at all feasible or possible, if we can maybe work on something to come from this committee down to the various districts and borough committees. Thank you.
Thank you, Keith. A couple of thoughts. First thought is the front page of this report, which is on page 23 of members' packs, is the key one in my view, because that lays out the terms of reference of this scrutiny committee, which has a statutory bearing, and the district and borough scrutiny committees. And so what we have to do is make sure we aren't scrutinising in two places, so we just need to be very careful on that and tiptoe around that issue very clearly, because we can't, particularly in the middle of a pandemic, ask our health colleagues or even social care colleagues to come and be scrutinised in 8 places in the districts and boroughs and equally here. And there is a danger we learnt through Francis, the Francis report mid-staffs, and Philip, I'm sure, could tell us lots of stories on that. Not today, Philip, but could tell us lots of stories on that where actually different people thought there was scrutiny being done in different places and it wasn't. So really critical that there is join up. I would recommend that what you take is what is critical in your local area and what is specific in your local area, and you identify those areas. I do look at some scrutiny committees and think some of their agendas are very health light. And the suggestion, and I've heard it in a few districts and boroughs, that you can't scrutinise health matters because it's all done by the county is just not right. And I would encourage members to go back to their scrutiny officers, and if any doubt, go back to Deb Breeden, County Scrutiny Officer, for clarity in that. So those would be my comments. I've got Julia first, and Julia may just add something before you come back in, Keith.
Yes, I mean, I think Keith in previous discussions has raised a very valuable point, and it's something that both myself and Johnny have had a discussion with. We've learned an awful lot over the last 2 years with COVID about how the value of the community and also, I think you've referred to it, Chairman, the better working relationships between districts, boroughs and the county. And both Johnny and myself believe that there is a real opportunity in terms of driving forward the public health agenda to actually have greater cooperation with the districts and boroughs, because there may well be things that they do better at their level. So I don't think it's so much a scrutiny function, but listening to Keith, I think it's more about the overview and planning for the future. And I think possibly some discussions about that, because I think that that partnership working is strong at the moment and we can make it even stronger. So I would just put it in the context that perhaps not scrutinising, but part of your role, as you well know, is that overview, that bigger vision. And I think that that discussion would be very helpful.
Thank you, Julia. Just let me add two thoughts. One is clearly, for district functions like planning, it would be perfectly possible to scrutinise, what is being done with a borough function and a borough responsibility. But otherwise, I think Julia's exactly right. How is the wider determinants of health discussion, public health discussion, actually being replayed in the districts and boroughs? And many district and borough councillors may not even have this on their agenda, in fairness to them. Keith.
Yeah, I just wanted to say, perhaps it's something that perhaps we could work up, myself, Julia, and the overview, Paul. Maybe we could put something together that would make sense to take back to, say, try it out maybe in the moorlands first, see what the response is, and if it's really negative, then obviously it's not worth going forward. But if it's positive and there's something that they think is worth taking forward in terms of their scrutiny process, which is really more of an overview thing, as you say, it's not really scrutiny at district, then I think that might be worth just pursuing to see what you think we could maybe do, and if we can be as an example, I'd be very happy to take that forward with Barbara and obviously with Charlotte as well, if that's okay.
I would certainly welcome that, and I think the time to do that probably is after Anne's session on the wider determinants of health.
Yes,
because I think this session today plus Anne's session next year, early next year, will inform those and actually have something which you can take tangibly back.
I think that would be great. Yeah, sometime after Anne's, if we can maybe get together and put something to take forward back to the district council, would be great. Thank you.
Anne Edgley, you're now frowning.
I just want to comment, actually. I think I'm the only person sitting in this chamber that actually got interviewed by the Francis Inquiry. And can I say to you, at that time, I was chairing our health at the borough, and I thought it only right, that we fetched the county and the people from that was creating all the problems and everything. Julie Bailey, as I might mention her, I fetched her to that committee, actually, for the hospital people to be able to come along and give their insights as to what was happening. And I've got to say, we got pulled over the roads by Francis by saying, you were the scrutiny, but we thought we were doing the right thing and everything, and in actual fact, we were, so it still resonates with me a little bit, thank you. But I do believe there is a lot of work to be done between the county and the boroughs, really, and we're missing an opportunity.
I think there are a number of us in the chamber who completely agree, and that importance of that working relationship is critical. But equally, we've got to be talking a common language, and I think we move in that direction. So that's positive. And I would just note that Philip Atkins was interviewed by mid-staffs, because he would just remind me after the meeting. So let's get it out in the open now. Can I just seek committee's thoughts in? Can I seek committee's thoughts in terms of item point 8 on this, East Staffs Borough Council? I noticed they've formed a subgroup to look at the impact on health of GP access. And I also note that the first group is subtly different to the county council work. I'd be tempted for committee just to see the terms of reference of that group, just to ensure and satisfy ourselves that it is separate to the work that the county council is doing. Philip, do you have any thoughts?
No, there was nothing reported at the last Scrutiny Committee at Burton, but they have got these two groups. Burton's got its specific issues around both of the topics that they've got. One is that there's poor, well, poor's not the right word. There's a lack of GP surgeries in the centre of Burton, and I noticed in one of the COVID updates, I think it wasn't the last one, it was the one before that Kieran sent out, there was only 36% uptake of COVID vaccinations in Burton. That's despite all the walk-in facilities at the Pirelli Stadium, the health centres and various others. I was at a Staffordshire Ambassador event at St George's Park, and I managed to have a quick chat with one of the key members of the Pakistani community in Burton and asked him what the issue is, and he said they don't know anything about it. Now, I know you may think that this is bizarre, but that is the community in Burton, and the communications that we're putting out aren't getting to them. So, you know, I think we're going to have to go through what I call the gatekeepers. And I know Saeed's been doing his best, but there are 7 mosques in Burton, and they are totally separate. So you've got to, you know, got to do work at it. And for Jamil to say to me, they don't understand it, they don't know anything, I thought was really quite horrifying. So putting those two things together, the second bit of work, I am really quite concerned about that. But they look after their own, they take care of their elderly in the same house, they're very close together. That explains some of the high infection rates for COVID 12 months or more ago, but it doesn't explain why there is a poor uptake of vaccinations, unless Kieran's finger slipped and he didn't mean to hit 3, but he meant to hit 8. But, you know, it was 36% in the members' update.
Thank you for that background, Philip, really useful. Clearly, I'm sure everyone in this committee would not want to find people who have not got access to the healthcare they need. Maybe my suggestion is that we ask eStats just to provide the terms of reference for the GP access piece, and maybe if it doesn't reflect what Philip is talking about, that we try and mould and shape it so it does, and if it comes too close to the central committees, county councils committees, terms of reference, that we also pick up that point. Are we in agreement? Thank you. Okay, has anyone got anything else they want to add? Daniel?
Just a bit of further information that's not actually within the report. It wasn't brought to the Tamworth's committee, but as a council we invited the voluntary sector to come and give talks on what they actually do and how they found COVID, which all members of Tamworth's Council and also the officers found really interesting. I'd just like to be able to maybe put the presentations into the committee so everyone can see them, because although it was Tamworth aimed, there was very broader points in there. Just another point on GP access. We've got a GP surgery in Tamworth that was burnt down a number of years ago, and a few practices are trying to speak to the CCG to see if they can take on that practice and get it reopened for the local residents, because they're having to travel quite a distance. But they've not had any responses from the CCG, which is quite concerning, and there has been a number of correspondence. Thank you.
Thank you for that. Just in terms of that last point, if you're not getting any response from the CCG, maybe just write to me, an email with the details, and then I will take that up with the CCG and ask for a written response, and that will be the appropriate way to do that, just to help.
Thank you, Chair.
Thank you. I mean, it is clearly a Tamworth-based issue, so I'm not trying to take over the point you've made, but more than happy to lend a bit of support.
Thank you.
Good, useful discussion, and I think you'll find that these discussions as we go and share best practice. I didn't pick up your previous point though. I think your point about creating a centre of excellence with case studies and other examples is a good thing, because then when people have similar questions or similar ideas, they can pick up that and just leaf through them and maybe come up with some ideas. And the idea of the web space we've created, the SharePoint library, is to exactly create that. So maybe if members start sending in not whole presentations, but break them down into the salient bits that relate to health, and then we can save them into specific areas and work backwards from there. Thank you. I'll move on, if I may, into the forward work programme. So I'm on page 31, I think. Just for members' awareness, we are very much still meeting on the 13th of December. That is a critical meeting to review the action plan that was agreed in terms of GP access and to see where we are against that action plan. And second of all, it is to take a system-wide approach, and you've heard that referred to a couple of times, to look at the issues that are being created within secondary care. So we're going to look from West Midlands Ambulance right the way through to discharge of medically fit and able people from hospital, and all points between. I'm understanding that we probably have a cast of 16 various senior execs from within various different providers to be able to illuminate the discussion. So I would encourage everyone to be at the next committee meeting. In terms of the date of the 24th of January, which was a tentative date for an inquiry day, that is likely to move backwards to February, hopefully not into March, but back into February. As soon as we've got a date, the issue is more about making sure we've got the right material to bring to you and to engage in those discussions rather than trying to do it prematurely. And I'm sure Anne would welcome the extra time, as would Deb Breeden. There you go. We will circulate for the care home slot on the 31st of January a cabinet report that has been done, or a cabinet briefing that has been done just to look at the care market, and that will be a subsidiary supplementary papers that we will circulate there. I would encourage anyone who wants to go to the Health and Wellbeing Board this Thursday, 3 till 5. It's online, so you don't have to physically go. If you happen to be in Stafford, it is in this room. But otherwise, I encourage members just to turn up to that and have a look at what they do on the Health and Wellbeing Board. In terms of the further agenda, I did take away from the conversation earlier a point about maybe scrutinising how interlinked the obesity and diabetes work is. I would suggest we don't diarise that just for a moment, but we put it on the future work agenda so we can pick it up. And second of all, I don't know what members' view on social prescribing is, but this is where GPs, medical professionals, try and refer people into the voluntary and into the community sectors. But there is significant money being spent on social prescribing. But if you ask medical professionals, GPs, or if you ask the county council, mental health, or any of the other public sector partners, everyone seems to have a different definition of this and be doing it in different ways. And it does strike me that it's being done. No, that may not be fair. It does strike me that it may be being done in different ways, and we might benefit from seeing what the plan is and to see whether there is a joined-up plan across all partners. Because actually, if I'm an individual, I want to be done with or for, but not to. And I think that we should just we may want to satisfy ourselves that that is the case. Does anyone have a view forward or Keith?
I fully support you in this. I think that there's been quite a lot of different approaches across the whole area, certainly just within my own divisions and district areas as well, is that some groups are very active, linking up with the social prescribing and NHS people, even to the point at one point where one of our groups was actually doing assessments almost on behalf of the NHS, as when they came out of hospital, they had their own assessment sheets to be able to help local people to integrate back into their homes. And then they were looked after by community groups within the things. And in other areas, people going, what's social prescribing? So there's quite a difference across the whole remit. And I do think that we do need to make sure that what we know is social prescribing and what the NHS knows is social prescribing and what community groups know is social prescribing. More or less the same, I hope, but I know even GPs and GP practices have different approaches as well. So I do think this is something that we do need to keep our finger on, and certainly something that we need in the work programme, and some ideas to who's even going to report this to us. Who are the members of the partnership? Similar to what we were going to try and do with the work after Anne. You know, it's again, different districts may be able to input different things back into what we then, by the end of the year, might have a better idea of what's going on. So I fully support that. Thank you.
Thank you, Keith. Really expansive, helpful. Daniel, you've nodded a couple of times. Did you want to add anything?
Just on the point that I spoke about earlier about the seminar that Tamworth did with the voluntary sector, there's a good piece in the presentation that I'm going to send round on one of the groups in Tamworth that actually has a dedicated social prescriber person embedded in that, and I think that would be a good way to link between the NHS and the community sector groups. So, Chair.
Thank you. Anyone else want to? Richard?
Chairman, it's just a reference, obviously last month, and the Wally's Quarry, and I don't want to obviously repeat everything that's gone on about that, but I was rather amazed by the owners now taking legal action against demonstrators, which just tells me that there is an issue still rumbling on that's never going to seem to be resolved. And I just wondered, where it says that updates will be in 3 months, that was in October and obviously January, February time, whether we will get those updates. But just as a record, I was disgusted, to be honest, with those actions.
I'm going to keep very closely to health-based issues within Wally's Quarry, and I'm sure some of the other issues would be adequately, very capably picked up by Newcastle and their cabinet and leader. So I'm going to stick off those, but you are right. In October's meeting, we talked about coming back in 3 months. I think probably, given that we have a late January meeting and a mid-March meeting, I think we should probably look to bring back Wally's Quarry in March, unless there is an escalation of issues, in which case we can bring it back sooner. I have to say I was pleasantly surprised by what the EA had to say at the last meeting, which is why I would suggest March might be an appropriate time. 2 Newcastle members, I've seen 1. Yeah, you happy with that as a proposal, March? Yeah, and if need be, if it is, and I hope it is, if it is completely resolved by then, and I doubt it will be, but if it was, we could handle it as a written report. You know. It is Christmas, Philip. It's goodwill to all men and women, and you know, even. Maybe not. And a final point, which I haven't raised yet, just in terms of health. We haven't got on our agenda. We've looked at very thematic things recently. Just mindful we haven't really done much of a scrutiny on UHNEM or UHDB, you know, some of our acute providers, and we shouldn't let that come off the radar. So it's a while since we've had Tracy Bullock, for example. You know, what are the development plans in some of our acute providers? And you know, and I'm not forgetting RWT or any of the other acute providers, but I think, you know, we may want to slot into the agenda going forwards, you know, not all on one day, but you know, three-quarters an hour for an hour to look at, you know, each of the providers and just make sure that we are satisfied. We have asked them some questions and satisfied ourselves they're doing the right things. And Angela.
Yes, just to comment on that, Chairman. I mean, the patient participation group, which I'm part of, they keep getting questionnaires coming out asking us about different, what we feel should be at the county hospital or what we feel, you know, so I agree with what you're saying about we should keep them on the radar and fetch them in. Because it must be 2 years since Tracy Bullock appeared in here.
Thank you. Is everyone else in agreement with that? I don't want to create more work because I think we have a big enough programme as it is, but we just need to keep our finger on the pulse. Good. On that basis, we have nothing in terms of exclusion of public, so I think that brings us to a natural conclusion for this morning's meeting. Thank you for making the effort to get in, and safe journeys home whenever you get there. And thank you for the attendance officers and cabinet members. Thank you.
Thank you, Chairman.